I'm having a little glitch or something. So anyway, let's see. I feel like I'm so close up. Hello. I hope everybody sees that message. I had the passcode as 126, but I met with a student this morning and I had the passcode on that meeting as 234. So I'm wondering if that somehow changed it. Because you saw that I copied and pasted it from the meeting I'd scheduled before. So that's odd that that happened. But when she went to sign in, she said she had the wrong passcode. But then she got in. So I don't know if you know, going through the same Zoom, it's changing it back and forth for meetings. So
yeah, I saw it as soon as you gave it, and I was typing it in and it wasn't working. I was like, uh-oh.
okay, so everybody's finding it, so that's good. Jess. Rachel, is that you, Rachel Roush? An iPhone? Who is this? Go ahead and unmute. Let's see. I'm sorry, what is your name?
My name is Madison. I'm fixing my thing right now.
You're Madison, okay. Somerville, gotcha.
Mm-hmm.
Morgan, did you get kicked out and let back in? I thought I let you in already once.
I think she's waiting to get back in.
Okay, I let her back in.
And apparently a lot of people are having issues with the ID and password. Like a lot of people aren't able to get in for some reason.
Yeah, they need to try, I just sent out an announcement for 2/34/2020. Somehow it took my 1/26/2020 password, and when I did a student remediation this morning, it changed your password to 230. Initially, she was trying to get in, and it was telling her it was 1/26/2020. And then when I changed it to 2/34/2020, it changed your pet. So I didn't realize that the classes, like if I set up a Zoom meeting, and I set up another Zoom meeting later and changed my password to my phone number, you know, that I couldn't have like 2 different passcodes for my phone number. Am I communicating that? Does that make sense? How would I have known that it was going to switch past scheduled meetings, the passcode on it? But now I know. So I don't know what I want it to be though. Do I want it to be 126 or 234? Maybe I'll just be NUR 2020. Okay, Melinda and Selena.
Miss Erickson, we're doing the second device thing for the exam, right?
Well, as long as I can see you on video and audio, okay? That's what I need.
Okay.
Okay. Is Esme here?
They're having a hard time getting on.
Okay. Did they message somebody? Did they? Let's see.
Yeah, we're on a group chat right now trying to send links and kind of help them get on, but I don't know if they're still having a hard time.
I was having a hard time and I'm in now, so there might be a few people, but I don't know if there's anyone else still struggling.
Let them know that it's 234-2020 is the passcode.
Miss Erickson, Brett's Wi-Fi just went off, he said.
Okay.
He's
Well, what-
he's trying to get it back up, but
Yep. We love computers. We love computers, right?
My sister lives in Brett's neighborhood, and they're like every time I go over there, their Wi-Fi is so crappy. My signal's so crappy.
we tolerate computers. We tolerate computers.
Right? We have the brain, they don't.
Yeah, that's actually the scary part.
Right? Okay. But did somebody text Esme? Let's see. So my plan for today, let me, okay. I think I've responded to everybody who texted or emailed me.
Yeah, you text me back, but I'm on already.
Okay. Oh, good. Okay. And then, did anybody get a hold of Esme? Is she getting in?
I'll text her.
Okay. And Shelby, you're in.
Or
Shelby, you're here, right?
yes, I'm here.
Okay. Okay. Mariah Bailey's here. Sydney Pamrod, Bramlett Penrod, Sarah Klein, Kaylee Engel, Bridget Geary, Shelby Green, Isla Guerrero.
Are you on, girl?
What's that?
Esma. Okay, so you're getting on.
Monique, you're
I'm
not.
talking.
That's
I'm
okay.
talking to Esma, Miss
Yeah.
Erickson. She's trying to get on.
Okay, I'm watching for her. I don't see it. I don't see it yet. Oh, Robert. Who's Robert's phone? Robert Kershaw. Okay. Okay, so the plan for today is you have until 3:15-ish for the exam. So we could even, I was gonna start lecture at 3:30. So if we go a little bit long, since we're getting a little bit of a late start, that's fine. But hopefully the exam, is 50 questions. It shouldn't take that whole time. But if it does, we'll just plan to resume lecture at 3:30. If that plan changes, I'll send out another announcement, okay? But that should work. And then we're going to move on to our concept of oxygenation. If it wasn't your first nursing concept, I might have considered doing like an asynchronous lecture. Sometimes that works well after an exam because, with people finishing at different times, sometimes it's nice not to have to wait and hang out and come back for a lecture. But since it's your first time getting a new nursing concept in its oxygenation, I wanted to do a live lecture this time. Okay, but in the future, I do change things up. So I don't want you getting discouraged thinking every week it's going to be 3 hours of live lecture. Okay, unless you're like, yay, we love 3 hours of live lecture every week. Let's do it, right? Then I'm game. But you know, I do like to change it up and do different things. Okay, so is Esme? I haven't seen her yet.
No, Esma is still trying to have problems, so she's trying.
Okay, but she's got the right passcode and everything, right? Okay, everybody do your 360 of your room with your camera so I can see. Okay, make sure that you're in your quiet room. And
You
turn
text
your
her the
volume down
passcode.
so you're not going to hear each other, right? But I'm going to have you unmute when we start so that I'll be able to hear you. Make sure your backlighting is on good. So I think I can see everybody. Let me just kind of look and see once you get done with that 360. Looks good, Monique. Thank you. Sarah. Selena, I can't see you yet, but saw your computer. And everybody's got the exam pulled up so you're ready once we're ready to begin. I have two computers going. Okay, sometimes I might get an unstable internet, so just watch. You know, if for some reason I get kicked out of the internet, you know, you might have to rejoin the Zoom, okay? But yay, there's Esme. Usually it's been okay. So Nate, can I have you move your camera down a little bit more so that I can kind of see? Yeah, thank you. Yeah, that's good. That's better. Okay. But then, and Selena, can I have you move yours down a little bit more too, please?
I can try. My phone keeps falling.
Gotcha. Okay.
So if I don't move it.
Yeah. Okay. No, I can see you. It's all right. Okay. I may, if I'm getting a lot of noise, sometimes it's hard to tell if there's noise coming from a certain place. If you're getting, you know, if something happens, somebody rings your doorbell or, you know, go ahead and mute and chat, you know, send me a message letting me know what's going on. Okay. 50 questions, multiple choice. There's a few fill in the blank with math, okay? Don't worry if the math, you know, I'll look at it, right? You'll have to show your work. So write it out on your scratch. Everybody's got scratch paper. And you need to be able to take a picture or download that in some way to the journal so that I will give you credit for your math work. And there's a journal in Blackboard. So after the exam, you'll text me, you'll chat me that you're finished in the chat box in Zoom. I'll say, okay, go ahead, download your math. You download that, then you mute and you tear up your scratch paper on camera. Okay. Any questions about that?
So we can't just like use a calculator.
You can use a calculator.
So,
yep.
Okay, so only if we take notes do we need to upload it?
No, you need to show me your calculations. You need to show your work so I can see that you have it set up correctly. Okay.
I have to go find some paper then.
Okay. So remember the Kaplan decision tree. The Kaplan decision tree asks you to identify the question and what it's asking first. Okay, so on your scratch paper, you can write down keywords to help you identify what is the question asking. When students get the problem wrong, usually it's because they missed a word in the question, right? So kind of identify, is it asking you an assessment type of question? Is it an intervention type of question? Can you apply the ABCs and prioritize? Usually the best answer, it relates to airway, right? You can't move on and do other things if your patient's not breathing. So prioritize, apply Maslow if you can, and apply your ABCs if you can. Usually physiological type of issues are more of a priority. Some of the pitfalls, you wouldn't pass the buck and say, we'll ask the doctor about that. You wouldn't leave your patient usually. You know, those are kind of some Kaplan guidelines that help you test take well, okay? Identify what the question's asking, consider all of the answers before you commit to the wrong answer, right? So consider, I like to say consider D, right? So read through each of the options. A lot of times it's helpful to think about what do you know about that subject before you even look at the answers. So you have an idea in your mind of what you know, right? Before you kind of might get misled by something that sounds good. And then if you know that certain answers are wrong right away, rule those out in your mind, right? So weed it down, pick the right answer. Don't change your answer from the correct answer to a wrong answer. Don't add to the question. Take the question at face value. Tom, you're not really missing anything. I'm just reviewing what you already know about test taking.
I could hear you.
Good, good. Okay. So I just always like to remind you that you have my permission to get an A on the test, okay? If you all ace the test, I'm just going to take credit as having taught you well, okay? So focus. I know you know this material because I've taught it to you and you've read it, and a lot of it was review from last semester, okay? So do well on the exam. Oh, here's Brett. Good. So I think everybody's here, right? If for some reason somebody gets kicked out and needs to rejoin, just don't worry about it, okay? Well, just be quiet and don't disrupt each other. And, you know, I'll mute you if I hear noise. If you're making noise and you can tell we're kind of looking for who's making noise, let me know it's you, okay? So that we're just being transparent about things. Okay. The password, I'm going to type it in the
Ms.
chat box.
Erickson,
Yes.
real quick, I'm sorry. If we're
No,
all done, what time did you want us back?
I'm sorry?
Once we're all done, what time did you want us back?
3:30. So
Okay,
I'm going to lecture
okay.
from 3:30 to 5.
Okay.
That'll be the plan. Okay. So that being said, everybody go ahead and unmute. And we're going to get started. The password for the exam is Thomas 0920. Thomas with a capital T, 0920, no spaces. I like to turn my video off so you don't feel like I'm watching your every move, but I'm right here, okay? So if you have any issues or questions, just private chat with me, okay? And Brett, I did announce to everybody there is a journal where I want you to post your scratch paper and show your work for your math equations. You may use a calculator, but you need to post to the journal to get credit for your math problems. Thank you, everybody. Good luck.
taking a test. I'm taking the test. Be quiet. Go in your room separately.
anything that I can do to help you? If I was staying, I would do my hotspot.
Outside.
Yes.
Do.
Yes.
Pretty cool.
Can I get Buddy a bath?
Shh, I'm in a test. No, close my door. Later.
Oh,
Close my door.
why not?
Because I'm in a test.
Baby, I'm in the middle of a test. Have some soda. Go ask TJ. I'm in the middle. No. I am.
Okay, I'm going to go ahead and start. Hope everybody's back. Okay, can everybody hear me okay? Can you hear me okay, Brett? Okay, so we're going to move on to our first nursing concept, which is oxygenation. Okay, so I think I kind of explained to you all what a concept is, right? So it's as professional nurses, nursing concepts are really our body of knowledge. So it's the different processes in the human body, or maybe it's a conceptual framework, like pain, for example, is a concept, right? So it's something experienced by the human, something in the environment that affects health. So we have these different nursing concepts. And the idea is that, you know, as a doctor, the doctor is going to diagnose, right? So we pull those exemplars in that we're going to be applying concepts to different exemplars. And those are usually, you know, doctors' diagnoses, like COPD is one of our exemplars for oxygenation. Reactive airway disease is another. And pneumonia, tuberculosis, you know, those are all medical diagnoses where we could look at the patient, we're going to see an alteration in their oxygenation. So, you know, what I think is really great is that as nurses, really, when you think about it, we're not as concerned about the medical diagnosis as we are about how our patient is presenting. You know, if they're having increased work of breathing, if they're not oxygenating, if they're not able to maintain their airway, right? That's where we're going to intervene. We don't care if it's from pneumonia or if it's from, you know, pleural effusion or what it is. You know, we'll fix the problem, we'll identify the problem, we'll fix it, but we're more concerned about making sure that our patient is oxygenating and perfusing, right? That they're not coding, and that, you know, they're not going to die on us, right? So that's really how we approach it as nurses. So the idea is that if you have a good understanding of these concepts, that instead of teaching you all the different exemplars, all, you know, what you need to do for cystic fibrosis, what you need to do for pneumonia, if we teach you how to identify an alteration in oxygenation, then you can take that nursing knowledge and apply it to whatever you're going to see out there. So this is evidence-based practice in terms of teaching nursing, okay? Because what we have found is that if we're focusing on just the exemplars, it's too much content. We're not going to be able to teach you everything out there that you're going to see. So if we teach you the concept of oxygenation and give you that knowledge, and then no matter what you see, you'll be able to apply it, that's how you'll get to be able to function out there as a new graduate. You know, maybe there'll be specific things that you're still going to have to go to your charge nurse or to another experienced nurse and say, you know, I see that this is an issue, but I'm not sure what I should do about it. Okay, there's still going to be little circumstances out there, but in general, this is what works. So that being said, what are some things that you know about oxygenation? Okay, what do you know, Sydney?
Well, in Pathio, we're learning about like issues with oxygenation, so like COPD, asthma, stuff like that. So it
So
has
in
a lot.
patho, you're learning those exemplars. You're learning specific things about what causes the diagnoses, right?
Yes, ma'am.
Yep. So you know, as a nurse, what I'll find is, you know, if you have 6 patients, and let's say it's respiratory season on the unit, right? And we often talk about the hallway assessment, right? So if you're walking down the hall, what might draw your attention to a patient that they're not oxygenating well, or that they're having problems with their breathing? What might you look for, Alexandria?
Wheezing.
Yeah. You hear
Maybe
that?
kind of choking on themselves.
Right? Or like our little Crouper kids that we get in pediatrics, they almost sound like barking seals, right? Or they have that inspiratory stridor. If it's, you know, like, you know, that's that high-pitched upper airway swelling that you hear. You know, if you really hear that loud stridor, they wake up and they're really having difficulty, you know, that'll draw your attention, right? So wheezing, so abnormal breath sounds, right? And sometimes you don't even need to put your stethoscope on that patient's chest. You can tell from the doorway, you can hear that wheezing, right? And what is wheezing a sign of?
Inflammation of the airway, not getting enough oxygen. Maybe the diffusion isn't working the way it's supposed to.
Yeah, well, you know, so sometimes we can't tell exactly like what's going on with the oxygen, you know, without monitoring, right? We might be able to tell from the patient's color, but the wheezing alone, you're right, is the sign of the increased inflammation, maybe of the lower airways, right? Where croup or something, you know, that stridor is the upper airway, the lower airways, then you're going to hear wheezing, maybe in the middle areas. So what do you know about the anatomy of the lungs? So how many lobes do we have on the left? And how many on, yeah, 2, there you go, Sarah, yeah, 2 on the left, and how many on the right? Right upper, right middle, right lower lobe. So however you can remember that, if you're right-handed, just remember you got more on the right than the left, right? 3 on the right, 2 on the left. It's always embarrassing when, you know, they have a lobectomy and you're listening and somebody's charting breath sounds on a lobe that's not there. Although sometimes the other lobe can kind of start to fill in some of that pleural space, and you might hear some deferred breath sounds or something too. So there's always an exception to the rule. Okay, so other things that you know. What's normal room air?
Well, if you were talking about hallway assessments,
Yeah.
you know, you can look at the patient's color, see if they're tripod breathing, if they're using the accessory muscles.
So explain what is tripod breathing, right?
Well, it's just kind of when they're leaned forward, like with their hands on their knees, kind of bent upwards, like, you know.
Yeah, they're sitting up in the bed and they're kind of leaning forward to try to expand their lungs. Yeah, that increased work of breathing.
That's kind of a hallway assessment.
Yep, so our book talks about this, different positions, you know, do they, are they use orthopnea, right? Is if they're needing a lot of pillows when they sleep. People who have congestive heart failure, a lot of times they're retained fluid, and then when they're sleeping at night, as that fluid absorbs, maybe their legs get swollen during the day, but then when they're sleeping at night, that extra fluid is absorbing into their body, and then they start to have more fluid around their lungs and they start to get short of breath. So, you know, we'll ask them, how many pillows do you sleep with at night? And that's called orthopnea, pillow orthopnea. Dyspnea means pain with breathing, right? Tachypnea is increased rate of breathing. Bradypnea is low. So, you know, I like to kind of tell the story of the 3 bears, right? Is it too slow, too fast, or is it just right? But then there's also, is it not there at all? And that's apnea, right? You put the A before it and it means no, right? So, you know, rate of breathing, so knowing what that normal respiratory rate is. So, you know, for adults, 12, 16, maybe 20 at the most. And then it goes up, right? Our newborn babies might breathe normally, you know, 40s or 50s for a newborn. You know, babies who are crying will breathe faster. But if you see somebody who's really tachypnic and working hard to breathe, you know, that hallway assessment. I was in the PICU with a student, and there was a patient that was working really hard to breathe. And I said, I turned to the student and I said, look at that patient. What are you worried about? You know, it's like a 15-month-old and she's just really working. You know, she's using those accessory muscles. You can see her chest just moving as she's trying to get that air in, and she's retracting. The trachea muscles are pulling in, the intercostal muscles around the ribs are pulling in, the middle of the chest right in here is sucking in, because she's using all those accessory muscles to try to pull air into her lungs. And, you know, her mouth is open and she's looking panicked. The student looked right at me and said, I'm afraid she's going to get tired and quit breathing. And I went, right? Bravo, bravo. Yes. So that's the issue, is that if somebody's working really hard to breathe, how long can they maintain that energy to breathe like that, right? Before they're going to tire out and they're going to go into respiratory failure, and then you're going to need to intervene. So, you know, as nurses, we have like that window of opportunity, you know, maybe we can suction, maybe we can position our patient, give them bronchodilators, give them oxygen, support their breathing, you know, comfort them if they're in pain, and maybe we can turn them around, but we don't want to wait too long, because we don't want to have to emergently intubate or have our patient, you know, go into respiratory failure and have to start CPR, right? So that's kind of right there on the edge, you know, when you're thinking about acute care nursing. When you're thinking about health promotion, what do you think? Here's what, I bet you know this about oxygenation. What do you think is the #1 risk factor for respiratory illnesses, for respiratory diseases? Stacy, what do you think?
Like what causes it?
Yeah, #1 risk factor for somebody having respiratory illness.
Obstructed airway?
But even more
Smoking.
preventative.
Quitting smoking.
Yes, that's where I was going.
Smoking.
Thank you for reading my mind on that. Yeah, so if somebody's smoking, even cutting down, right, can help them, you know, have improved lung function. Quitting all the way is even better. And then the longer time that they've gone without smoking, the more that the lungs can kind of heal. The cilia, the little hairs, the fine hairs that help kind of clean out debris in our lungs and help us cough and clear our airways, right? Can start, those get damaged with cigarette smoke, let alone all the toxins that, you know, the cancer causing toxins that people inhale. So, yep. Okay, so, and you know, and then we look at our environment, you know, all the smoke that's been coming into Tucson. There's been a lot on the news about air quality, right? So I think there was some report about how the firefighters were getting exposed to smoke from the fires that was equivalent to smoking so many packs of cigarettes a day, right? Did you guys hear that on the news? They were talking about air quality. Okay, so I'm going to go ahead and share here, and we'll get started with our PowerPoint. But, you know, just to get you thinking in terms of what you already know. I mean, we're living, breathing people, right? So, and I don't see you guys. Okay, share screen. There we go. Let's see how I can see these guys and let them in. So there's some people who need to be let in, huh? Where'd they go? Okay. You're in, Trevor? Okay, so Welcome to the concept of oxygenation. Did you catch the little song, right? Let's talk oxygen, oxygen, let me see you oxygenate and ventilate, right? I don't know. You gotta kind of syncopate a little bit, don't you? So oxygenation is actually the mechanisms that facilitate or impair the body's ability to supply oxygen to the cells, right? Our cells need to be oxygenated. We need to be perfused with blood that has oxygen in it, or the cells die. They become hypoxic and they die. So the two parts of that is the respiration, the actual gas exchange, and then the ventilation, the actual breathing. So the airway is composed of upper and lower respiratory tract. The respiratory system obtains oxygen from the air, which is at about 19 to 21% for room air, and transports it into the alveoli. The little ends of our airways are these little pouches, these little sacs, the alveoli sac, that then the capillaries of the venous, the arterial system, our arteries, little capillaries, come around each sac, and that's where the gas exchange actually takes place. So we have to have adequate perfusion around, and we have to have adequate oxygenation into the alveoli sacs for that gas exchange to take place, and for oxygen to be transported into our circulatory system and then to be circulated out to the cells of our body, right? Especially our brain, especially our heart and our lungs and our kidneys, right? And our vital organs. We kind of tend to, you see this in like newborn babies, right? They kind of get peripherally hypoxic. They might have some cyanosis in the peripheral area, this bluish color, right? In their hands and their feet, because the body kind of shunts into the major organs of the body. So we might get some circummoral cyanosis. You might see bluish tinged around the eyes and the mouth too, as you look at the changing color with people who become hypoxic. Also remember that if we are not getting enough oxygen to the brain, our neural system, assessment of the neurological status of your patient, how alert they are and how aware they are of their surroundings, is closely related to that respiratory assessment. When people aren't getting enough oxygen to their brain, they become very disoriented. So and sleepy. So the respiratory system obtains oxygen from the air, transports it to the alveoli, where the oxygen diffuses into the capillaries and is carried by the blood to all the cells in the body. And this also exchanges the oxygen then from carbon dioxide, okay? We're gonna really connect the concept of acid-base balance to oxygenation, okay? There's only two ways that our body gets rid of acid. So in our body, we're always producing hydrogen. And hydrogen's a positive cation. It's always part of that acid buildup in our body. The only way to get rid of that is through exhaling CO2 in our lungs and excreting it in our kidneys. Okay, so lungs and kidneys, we're going to talk about that more in the coming weeks. So just remembering that we take in oxygen and we exhale carbon dioxide. And we'll take a quick break, and I'll pull up this YouTube at that time, or when you review the PowerPoint, you can watch it on your own time. So normal respiratory rates across the lifespan. Newborn, 30 to 60, infants, 20 to 40, preschoolers, 20 to 30, age 6, 16 to 20, adolescent years, 12 to 20, adults, 10 to 20, older adults, 12 to 24. Okay, depends on what they're doing, if they're sleeping, if they're awake, if they're active, you'll see a variance in normal ranges. So normal drive to breathe. Where is our breathing? Where's the respiratory center controlled, Selena? Do you know, Selena? It's kind of in the back part of our brain. So people who get, what's that, Monique?
Is it your medulla?
Yep. Yep. So, people who get hit in the back of the head, the head injuries, we have to be very careful about how that's going to affect their respiratory center and that respiratory drive. And also, when we have a buildup of CO2 in our bloodstream, that also there's respiratory centers that then get stimulated, and that stimulates us to breathe to get rid of that CO2. So hypercarbia, increased CO2, drives breathing. Receptor sites in the aortic arch detect carbon dioxide levels circulating in our system, and they trigger either increased or decreased respiratory drive. Patients in the hospital, one of the ways that we control pain is to give them a patient-controlled analgesia device, okay? It's a really cool IV machine, and they get a little button that lights up when it's time that they can give themselves a dose of pain medicine. But they have to be awake enough to be able to push that button, right? Remember our scenario with Josie King, right? The nurses were pushing that button. Well, the problem is somebody else pushes the button, they can over-sedate that person, and they can decrease their respiratory drive, and then their CO2 levels build up, and they're not able to respond because they've been sedated. So we put end-tidal CO2 detection on these patients. It's like a nasal cannula, but that shows, that gives us that reading of their exhaled CO2. And if those numbers start to go up, then we know that they're getting too sedated, and we can decrease their patient-controlled analgesia, whether it's morphine or hydromorphone or whatever it is, okay? So we want to monitor those patients for CO2 levels. So what are some considerations that should be taken into account when thinking about the infant or child's airway? Trevor, what do you think? What's different about a child or infant's airway than an adult's airway?
Well, obviously the size, like infants aren't as developed as adults are. Yep,
Exactly, right? So, and it's very narrow. So when there's airway swelling, it increases, that swelling inside, then decreases the diameter that they can breathe with, right? So they're much more at risk for airway occlusion. And they're also developmentally, we think about, I'm thinking about the different, growth and development theorists, right? And how that, Freud in that phallic phase where everything's going in the mouth, right? So infants are going to take things and put them in their mouth. So things like latex balloons, #1 leading cause of choking deaths in children because they can't get that cleared. If the balloon breaks and gets lodged in their throat, it's very difficult to do the Heimlich and clear it. We know to cut hot dogs lengthwise and watch children, that can occlude their airway. There used to be these little Fisher-Price toys, and they had to change the size of the Fisher-Price toy because it was like the perfect size to fit in a toddler's airway. And what did the kids do? They put them on their fingers and they stuck them in their mouth, So we know that, like, you take a toilet paper roll dispenser, the cardboard, and if the toy can fit in there, it can fit in their airway and occlude it. So, yep. So they're really at risk. So in infants also, their airways are immature at birth. So they have millions of alveoli, but they're premature. They don't have as much surfactant if the baby's premature. And then children also have these shortened airways too. So increased risk for obstruction. Alterations to oxygenation. So how can oxygenation be impaired, Shelby? What are some ways that we talked about? How can oxygenation be impaired?
Oh my gosh, I just drew a blank. Like in adults or anyone?
Anyone. So generally.
I mean, if they have asthma can impair oxygenation.
Yep, right. So if they have impairment to the airway, yes. Yeah, good. So if I'm breathing faster, I'm going to have more gas exchange. Or if I'm sedated and I'm not breathing enough, right? If I go apneic, obviously oxygenation is going to be impaired. Obstruction, like you talked about, asthma, if my airways has increased swelling and I have an obstruction there, if a child falls in a pool and they're getting water in their lungs and they have a submersion injury, right? Or if they have reduced blood flow, somebody has like a pulmonary emboli, right? They had a DVT down in their calf, and they went and got up and started walking, and that DVT moved and went to their lung and cut off blood circulation to all that area, all that alveoli, right? That's going to reduce oxygenation. And that's a leading cause of death. We'll talk about that with perfusion too. I'll show you a video of a pulmonary emboli. So primary concern when oxygen is altered. Bridget, what do you think happens? Your patient has an alteration in oxygenation. What are you worried about?
Maintaining their own airway or keeping up a proper oxygen SpO2 rating.
Good. So two things, two nursing diagnoses that you just whipped right out there, okay? Alteration in airway clearance ineffective, right? Or alteration in oxygenation. So alteration in oxygenation and alteration in airway clearance. And then there's a third nursing diagnosis that goes along with oxygenation. So oxygen delivery to the tissues, if that's impaired, then we're going to have hypoxemia, which then leads to acidosis, that buildup of the CO2, which leads to death to the cells that are affected by it, right? So if we have impaired respiratory rate, so increased work of breathing, so alteration in breathing pattern, an alteration in airway clearance, or an alteration in oxygenation, tissue perfusion, leads to hypoxemia, low oxygen, buildup of CO2, acidosis, and death of the cells. So what is hypoxemia and how do we measure it? Allison Johnson, how do we measure, so you're looking at your patient, how do you know if they're hypoxic?
The saturation of their blood.
Yeah, so how do we measure that?
With the pulse oximeter.
Right, so we can do it non-invasively with a pulse ox. What are some of the drawbacks of putting a pulse ox on a patient? What can affect it?
If they have nail polish on, or maybe they had some issue that, decreases the circulation through their arm.
Right, if they're really cold, if they have a cast and it's obstructing blood flow to that extremity, right? So yeah, if they're moving a lot and it's not taped on well, we love that, don't we? And sometimes those pulse oxes, they seem to have a mind of their own. They're laying out on the bed, and what are they measuring? We don't know, but they're getting feedback from somewhere out in the atmosphere, and they're giving us a reading, and it's not even on our patient, right? Have you ever seen that? Those of you, I see, there's some of you that have experience with, the limitations of peripheral monitoring. You got to pay, and sometimes when they're moving or seizing or that kind of thing is when you actually need to be monitoring them the most accurately too, if they're really in distress and they're moving a lot. So yeah, so there are, and of course if they've been had carbon monoxide poisoning, or if they're really anemic, right? If they don't have enough red blood cells, you can have 100% of your red blood cells saturated with oxygen and your reading's 100%. But 100% of what? If they're that anemic, if they've had that much blood loss, they're still not oxygenating their cells well enough. So decreased level of oxygen, measured two ways. Okay, the pulse ox is your non-invasive way of, most of the time, that's, 90% of the time that's going to be adequate. But then the more accurate way of really getting a measurement of the oxygen and the CO2 and the bicarb, right, and the other readings is to get that either arterial blood gas. You could get a venous blood gas, but it's not going to give you that accurate oxygen. It's going to be a lower oxygenation because it's the vein versus the artery. Okay. Of course, we're assessing it when we're looking at the patient's color and their mucous membranes and their orientation, how well is their brain perfused. What assessment components would be seen in an individual experiencing hypoxia? I'm sorry, I just gave that away a little bit, didn't I? So color changes, work of breathing. They might be doing some like air gasping. So shortness of breath, increased respiratory rate, difficulty speaking more than 2 to 3 words at a time. They're going to be tired and maybe irritable, maybe headachy. Cyanosis, either peripherally in the extremities, as you know, the body's shunting that blood, that, you know, any oxygen it can to those main organs, to those, you know, and then central is considered that late sign of hypoxia. If they're looking dusky all over, they're in trouble. Okay, so respiratory alterations. Reasons respiratory rate would be increased. Okay, Madison, what are some like good reasons somebody might start to breathe fast?
I guess pregnancy would be a good one. Maybe like stress or anxiety, asthma.
I'm just exercising and I'm wanting to get more oxygen to my body, right? What about fever? How would fever affect respiratory rate? What do you think, Sarah? You go by Sarah or Chanel?
I go by Chanel.
Chanel.
I can go by either, whatever you want to call it.
Chanel.
How would fever affects it because your body's trying to cool off, so it's trying to get rid of that excess not acid, but like the excess carbon.
Yeah, you have that increased metabolic rate from the fever, so you're going to start breathing faster, right? What about pain? How does pain affect respiratory rate? A lot of times people are going to breathe faster when they're in pain, right? So consider that as a reason, especially for our younger children. So we look at blood pressure, we look at respiratory rate and heart rate as signs of pain. You know, sometimes with fever, kids can look really yucky. And then you give them some Tylenol and you get that heart rate and that respiratory rate down, they look a whole lot better. So anxiety, airway narrowing. Anybody, have you seen somebody who's had like an acute asthma attack and they're really anxious and they're breathing fast, and it kind of it makes the whole thing worse because they're panicked because they're having trouble breathing, and it kind of perpetuates that increased work. Pregnancy, that was very good, Chanel, you're right. You know, you have that pressure of the baby on the lungs, it decreases that lung volume, right? A different way of obstructing the airway. And that initial onset of a pulmonary emboli and fever, of course. Respiratory rate would be decreased. I talked about how if the CO2, right, that kind of hypercarbemia drive is being wiped out, head injury, oversedation, right, obstruction, drug overdose. So, you know, we hear about, you know, giving Narcan out on the streets and resuscitating people, but then Narcan has a short half-life, so you got to really be prepared to give a second dose. You know, most of the time the half-life of Narcan is, you know, much shorter than the half-life of the narcotic causing the respiratory depression. Abnormal respiratory patterns.
There's also Narcan drips, right?
Yeah, put them on a drip. Yeah. Robert, so we talked about some of the abnormal respiratory patterns. What are some abnormal breathing patterns?
Bradypnea.
Right, so too slow.
Tachypnea.
Right, too fast.
Apnea.
Apnea, yep. Babies that have immature respiratory centers, it's not unusual to see this periodic breathing with newborns. They kind of sigh and then they, you know, and it kind of freaks parents out. And, you know, you got to watch them, because if they're having periods of apnea greater than 15 seconds, 10 seconds, you know, we'd be concerned. But sometimes some of it's just from being immature. There's end of life breathing too, right? Like Cheyne-Stokes, Biot's breathing that can be associated with head trauma or, you know, respiratory failure. And then has anybody heard of Kussmaul breathing? Well, you will, right? You'll learn more about it this semester. Jess, do you remember what Kussmaul breathing is? What disease is that associated with?
Is it the one that you have like a few like quick breaths and then slow?
Yeah, that might be more the Biots or the Cheyne-Stokes. The Kussmaul is the fast, really rapid breathing, and their breath has a certain odor to it.
That's the one for DKA for diabetes.
DKA.
Exactly. Yes, they have that. They're getting rid of those keto acids, right? So with diabetes, specifically with type 1 diabetes, you don't have enough insulin, so your body's not able to facilitate, the breakdown of carbohydrates and getting that glucose into the cell. So your cells don't have enough nutrition, so you start breaking down fats. Byproduct of the fats are these ketones, these ketonic acids. So you know how I talked about with breathing, with your respirations, that's one way of getting rid of that acid, right, is through respiration. So they breathe fast to try to get rid of those increased acids, and you can actually smell it on their breath. It smells yucky. It almost smells like anesthesia when they come out of anesthesia, and you can smell that anesthesia on the patient. It's kind of this very fruity, yucky kind of smell. So, and the breathing's very fast. So we have to go ahead and we have to correct that acidosis in that patient. Okay, so too fast, too slow, not breathing, pain with breathing or labored breathing. We talked about orthopnea, difficulty breathing when supine. Kussmaul breathing is that deep labored breathing, often associated with severe metabolic acidosis. So DK, but also kidney failure can create that acidosis, metabolic acidosis in the patient. Cheyne-Stokes respirations is this progressively deeper and sometimes faster breathing, followed by decreased breathing, which can lead to apnea. And Biots breathing, characterized by quick, shallow inspirations, followed by regular or irregular periods of apnea. Both of those are kind of associated with head injury and end of life kind of situations. So kinds of obstructions that can impair oxygenation, right? Upper airway, lower airway. So mucus in the airways, right? Nodules and tumors, pneumonia, pulmonary edema, foreign object that gets inhaled if you aspirate, right? Kids like to, aspirate beans, little pinto beans or, other objects. So all those things can obstruct the airway. Signs and symptoms in a patient with an airway obstruction. So Nathan, somebody's choking. What's that universal sign of choking? What do we look for?
Just kind of grabbing at their neck and
right. And you go up to them and say, I'm a nurse, I know CPR, are you choking? I can help you, right? And you get their permission and they're like, yes, please, relieve. And so then what do?
Well, it used to be called a Heimlich, whatever they call it
Yep,
now.
you Heimlich them, yep. You come behind them, you put your fist around right on that belly button, and then you, with that force, right? And then they cough up that piece of sandwich or something, you clear their airway. Yeah, so they're gonna, what's their face gonna look like?
Apparently panicked and kind of stressed.
Yep. And can they, if their airway is completely occluded, how would you know that?
Trying to speak, but they can't. And
yep.
They're not moving any air.
Exactly. Yep. So if they're not able to cough, no airways moving, we know it's a complete obstruction. Yep. So complaints, if they have asthma and they're having increased airway obstruction, they might say that they feel like they can't breathe. They'll have that increased respiratory rate because they're anxious with a decreased respiratory rate if the obstruction is not corrected. Hypoxemia, and then they'll have anxiety. So what's the goal of correcting an airway obstruction? So your primary diagnosis, right? Alteration in airway obstruction related to what if it's an pneumonia and it's the lower lungs, as evidenced by decreased breath sounds, coughing up thick mucus, right? Patients stating they feel like they're struggling to breathe and move air, use of accessory, this is the thing though, okay, we're looking at airway obstruction, so we want specific assessment findings that support airway obstruction. We don't want to, what I call getting out of our lane, okay? We don't want to deal with respiratory, breathing pattern. We don't want to deal with that they need oxygen because that's an alteration in gas exchange, right? So don't get out of your lane with your other nursing diagnoses. Stay in your lane with what are my measures to clear the airway obstruction, to keep the airway patent throughout my whole shift, because that's my goal. Patient's airway will remain patent through my entire shift. Sometimes if you just meet that goal, you're doing good, right? As a nurse. We say, that's kind of a nursing saying, right? You get done with your shift and you walk away and you say, well, they were all breathing. Sometimes that is the goal. Maslow's hierarchy of need for the nursing department. Remove and eliminating the obstruction to increase respiration and ventilation capabilities. Yay for tissue perfusion, right? Oxygen to the cells. So then we have our blood flow alterations. We don't call it the circulatory respiratory system for nothing, right? You really can't have one without the other. They kind of go hand in hand. So I think I kind of explained, right, Kaylee? Why is blood flow important to oxygenation?
To get blood throughout the body, the tissues.
Exactly. Blood carries that oxygen to the tissues. Yes. Right. So you need enough red blood cells. The red blood cells are the part of the, the hemoglobin, the heme on the red blood cell that's bound with the red blood cell carries that oxygen molecule. So the vascular system delivers the RBCs to that alveolar, right? The alveoli, the little pockets where the oxygen are, diffuse into the capillaries. And then that CO2, right? It goes both ways. Oxygen goes in, CO2 goes out. Without adequate blood flow, ventilation cannot occur, and neither can tissue perfusion. So what kind of blood flow alterations can affect oxygenation, Brett?
Basically,
What was that? You
if
froze.
you have like hypertension, if you have
Is he breaking up for everybody? Okay. Let me call in somebody.
hypertension,
Oh, hypertension. Okay. So increased systemic vascular resistance.
or
Yeah, you're breaking up, Brett.
perfusion,
Stacy Kirkpatrick, can you help him out?
yes. Can you, okay.
Did anybody catch what he was saying as I'm kind of interrupting too?
What kind of blood flow alterations can affect oxygenation is the question?
Yes, yes.
Yeah, I don't know.
Okay, that's okay. We have the answers right here. Okay, so we talked about pulmonary embolism, right? So what happens with shock? If somebody is in septic shock or hypovolemic shock, if they don't have enough blood circulating volume, right? If they hemorrhaged out. So if you don't have enough, so you were talking, I think you said hypertension, right, Brett? So if you're so hypertensive that then blood perfusion is not getting to your feet, right, or to your little vessels of your eyes because it causes damage to them, then yeah, you have death of those cells, you have neuropathies and stuff and kidney damage because you're not getting enough perfusion there over time. But then also if you don't, I'm sorry, if you don't have enough blood circulation because you're hypotensive, you're also not going to have enough blood circulation and oxygenation to the cells. So both of those things can cause acidosis also. Blood loss, hypertension, you talked about. So blood flow alteration continues, the ultimate outcome, right? Death, because you're not going to have enough blood flow to the lungs, reduce ventilation, reduce oxygenation to the tissues, death to the cells. Always remember that it's called the cardiopulmonary system for a reason. One can't function with the other. Can't have one without the other. Okay, so what are we looking at with assessment again, right? We're looking at that patient holistically. We're going to systematically inspect, auscultate, percuss, palpate, and ask our questions. Get that history. So what are you inspecting for? What kind of things? And we talked about from the hall, right? So you're walking in, you're looking at work of breathing, right? How oriented are they? Are they sitting up and they're looking around? If it's a child, you know, are they reaching for their mom? Are they reaching for their toys? Or are they head bobbing, right? What does that mean? Like if you see somebody and they're really struggling to breathe and they're kind of dropping their head, what would that be a sign of?
They're getting
Loss
tired.
of consciousness.
They're getting tired out, right? They're starting with respiratory failure. That's kind of that's a telltale sign. Okay, you see that and you really want to jump on that assessment, make sure they're not getting too tired. Yeah. So we're looking at color of our patient, work of breathing. We can see, what do we want to look at with the trachea? Where should the trachea be? Midline, okay? What if we see the trachea shift one way or the other? What can that be a sign of?
But there's an obstruction.
Right.
Or
Lung
damage.
collapses on one side, trachea is going to move. Yep, so then we want to look at how is the chest expanding? Chest expansion should be symmetrical. We should see both sides of that chest rising and falling together. And the trachea should be midline. And our patient should be alert. And they should be breathing easy, right? Then it's a good day. What auscultation? So then we start to listen, okay? We get out our stethoscope comes off from around our neck, right? Goes in our ears. We put the diaphragm to our patient's chest. Where are we listening? How do we do that? How do we perform that? Mariah Bales, you're auscultating your patient's lungs. Tell me, how do I do this?
Well, you're looking for like wheezing and the lung sounds.
Okay, so I'm listening to inspiration and expiration with the diaphragm, right? Either the front or the back, right? So I'm going to start anterior at the top of the lung. From side to side, I'm going to listen on the top of the lung and then go across and down and across and down, comparing side to side, right? How's those breath sounds on inspiration? And I'm going to ask my patient, take good deep breaths through your mouth, right? So I can watch and listen as they take a breath in, take a breath out. Am I hearing wheezing? Am I hearing other, we call those adventitious sounds. Abnormal sounds are adventitious sounds. So whether I hear rhonchi, like secretions in the lungs that cause this crackly rhonchi noise, or rales. Under your textbook, your MedSurg textbook, to the left, your student resources in the point, there's heart sounds and breath sounds. I don't think it's the same as hearing it for real, but it gives you an idea of the different adventitious sounds. Depending on where you breathe, there's a whole chart in your book about how you'll hear these inspiratory and expiratory sounds. Different areas of the lungs, you're going to hear things more anterior, you're going to hear more inspiration and expiration. You just hear it in different ways. So that's in the chapter here on auscultating breath sounds. So, but just know that you're going to listen side to side for abnormalities, and you work top down, and you want to pick a good, 8 spots to listen on each side, working down and working your way outward on the bases of the lungs too. Listen posterior, listen anteriorly. As you're assessing your heart sounds, also listen to your breath sounds on the front of the chest. Sometimes with people who are really overweight, you have some chest impediment. It might be kind of hard to hear. Sometimes having them lean forward and you can hear their breath sounds better. Okay, moving on to percussion. So as we tap, we take our finger and we'll tap with our other hand over that finger. When you're not doing it over bone, you'll just get dull sounds over bone. But if you're getting dull sounds over areas where you should be hearing air, you should be hearing more timpani, a little bit higher sounds as they're taking a deep breath in. And and if their lungs are filled with fluid, you're going to get more of a dull sound because you're not getting good air movement in the lungs, okay? It's a little bit more of an advanced technique, not as helpful usually as auscultation and just inspection. You can really tell a lot about your patient's you know, work of breathing and everything by inspecting. And then the last one, of course, is palpating, right? And we're looking for nodules and for tenderness, for pain, you know, swelling of ribs, anything like that, as we're palpating down the chest. Another thing that we can percuss is we can have the patient say 99, 99, and you can feel this on your chest. If you say 99, and guys with deeper voices, it's going to, you're going to feel that tactile fremitus better than women with higher voices. It just resonates. So you want to feel that resonance. If you don't feel that vibration, that's a sign that there could be fluid in the lungs. It doesn't conduct as well. So you can feel down the chest for that kind of, and then if they actually have like air leaking out through the lungs out into the extremities, you can actually get like this Rice Krispie where you can actually feel the air popping under the skin. And that's crepitus. Crepitus, yeah, with a C-R-E-M. That could be like our word of the week. So if you, that's kind of fun to feel, but hopefully it doesn't mean that your patient has blown a pneumo or something and has, you know, air leaking out through their lungs into the, under the skin. Sometimes you'll see it in patients that have had laparoscopic procedures because they use air, you know, they use that gas to blow up the abdomen and move the organs away. And then as it absorbs, sometimes they'll get a little crepitus under the skin. So, and then what kind of questions are you going to ask? Isela, what kind of questions would you ask your patient?
Maybe like what their lifestyle is, or what do they do at home, smoking?
Yeah, right. Yes. Do you smoke? Are you interested in quitting smoking? Right. And then what other things about their home are you interested in?
Medications.
Okay. Yep. Are they, you know, do they take medications to help them breathe? Are they, you know, on Pulmicort, or do they have an inhaler, right? Do they have a history of asthma? Do they have a history of frequent lung infections? Have they had any exposure possibly to tuberculosis or any other respiratory illnesses? Of course, you know, this time of year we're going to ask about COVID, right? Or any cough, recent coughs or changes in their breathing. Have they ever coughed up blood, right? Would be an important question maybe. Are
they up to date on their flu vaccine or the pneumonia vaccines?
Very good, especially for our older population, right? We want to know about that. You know, if we're admitting them into a long-term care facility, we're going to want to know about their pneumonia vaccine. And yeah, do they sleep with pillows, right? Do they have a history of any heart problems too? Because, you know, heart's going to affect lungs. Do they have a job where they have any environmental exposure to anything that affects their lungs? Any history of asbestos exposure? Lung cancer in the family? Anybody in the family with cystic fibrosis? You know, so we're going to ask questions like that. Any history of shortness of breath? What about allergy to things like, you know, anaphylaxis, right, to peanut allergies or latex allergies that have affected their breathing? You know, all those things that we need to know if we're going to take care of that patient, right, to be safe, to make sure that we know their respiratory history, we know their risks. And then, you know, specific to their assessment too, what kind of secretions are they coughing up? You know, if it's a baby, you know, have they had any periods of apnea or any color changes, right? Diagnostic tests. So we talked about getting the pulse ox, right? Getting the chest x-ray, getting the ABGs or the VBGs, getting the blood gases, okay? What are some other good diagnostic tests that I'm gonna think of? You know, a patient might come in with a respiratory infection. Before I start antibiotics, what do I wanna do?
Sputum culture.
Yeah, right? If they're coughing up stuff or if we're suctioning out stuff, we're gonna get that sputum culture and send it off and actually, you know, grow that organism in the lab and test different antibiotics on it and see what antibiotics, you know, treat that infection. What is that organism susceptible to? So it's a culture and sensitivity, right? So we're gonna look for that result, or get, if it viral cultures, maybe we're doing swabs up in the nose, throat culture for strep maybe, right? Flu, if we're doing a quick flu swab or something like that, we could get those kind of labs, right? Maybe we need a CT, maybe we need a chest thoracentesis, maybe we need, for the person with asthma, maybe we need like a pulmonary function test, right? We need them to take a deep breath and exhale as hard and as fast as they can, and we'll see how swollen are those airways and how well can they expel air, okay? In our post-op patients, we might want to do the incentive spirometer, see how well they can slowly inhale and what their lung expansion is like. Anybody think of any other diagnostics? Pulmonary function tests, you know, expired minute volume, the pulse ox, chest x-ray, bronchoscopy, right? Because they can actually like go to the GI lab, have a scope down there, get, you know, tissue samples of the lungs, get a culture of the lungs, or remove a foreign, if they can see, you know, they swallowed one of mom's earrings or they inhaled one of mom's earrings, right? Or a penny. That used to be my favorite. I had to take care of all the kids that had a penny stuck in their throat, right? Or in the trachea. And they were having, you know, inspiratory, expiratory stridor because they had this penny. One time, they sent this kid, I think from Wilcox, Benson area or something, that came, private car, you know, the x-ray was clear, right? Oh, the x-ray was negative. I hold the x-ray up to the x-ray box and I see Lincoln looking right back at me right here. I'm like, wait a minute, I think they misread the x-ray. You know, that's what's fun when you get to clinical and you can pull up Epic, you can pull up these films and these chest x-rays. I like to look at the x-ray first. You know, I've listened to the patient, I look at the x-ray, I see what I think, and then I look to how the radiologist read the x-ray, and that kind of helps me because, you know, if I could read x-rays really well as a nurse, I wouldn't be a nurse, right? I'd be a radiologist. But, you know, kind of nurses, we get to be jacks of all trades, right? So the more that we look at those x-rays and look at how the radiologist reads it, the better we get at looking for abnormalities and identifying them. You know, we start to look at, oh yeah, I wasn't hearing good breath sounds in that left lower side. Sure enough, look at that, you know, he's got a nice big infiltrate right there. No wonder, you know, this person might end up with a thoracentesis or a chest tube on that side, right? Our ABGs, peak expiratory flow rates, those are, you know, done on people with lower airway swelling, people with asthma. So, you know, next week we're going to get into our exemplars with asthma and COPD. And how are we doing for time? Yeah, it's 4:30. Okay. So we're going to talk more about asthma. I just want to look at these real quick. But we're going to do this next week, because next week then you're going to have your team projects where you're going to do a care plan on these different exemplars. And then we're going to get into acid-base balance. This is next week's stuff. So I'm going to stop this. If you guys want to take 5 minutes and go get a drink or something, I'm going to be pulling up a different PowerPoint, okay? And we'll look at some other resources, and then we'll call it a day, okay? Just a quick break.
Hey, Miss Erickson.
Yes, hi, Brett.
I just wanted to let you know I'm really sorry about my Wi-Fi being so
no apology
unreliable
needed.
right now. I have no idea why it's going on. I'm going to try and figure it out, but this is the worst it's ever been. It's never happened like this. So
it's so frustrating, isn't it? I
Yeah.
feel for you. I know. I've been there. And I know it's outside of your control, so no apology needed. I just feel bad for you too. I've been there.
All right, thank you.
And don't worry, I'll post the lecture so you
Okay.
can fast forward, you know, and catch the stuff
Awesome.
you may
Yeah,
have
that'll
missed.
be helpful. Okay, yeah.
Yeah,
Thank you.
you bet. Okay, so as everybody's coming back, I just want to show so in the point, everybody knows how they have these, I don't know if you were, how familiar you were before and how this was set up, but before the concepts came up differently. And now, you know, you have these little links right here, right? Everybody's familiar with this? So if we go to our concept view, and then we go to our class. Now, you all know that if you want more than just like the concept view for the class has been filtered out a little bit. So if you want to look at everything that's available to you, you can still go to this concept library and you can pull up all the exemplars and everything. But for the more filtered version, we go to our class and we look at that concept of oxygenation for our different exemplars. So we have asthma and COPD. So TB is going to be under the concept of infection. So tuberculosis is under the concept of infection. And then our fourth one is pneumonia. So what I like about these 4 exemplars for this next section for our test. So for the next test, so this week we're getting introduced to oxygenation. Next week we're covering our exemplars of PNA for pneumonia, RAD for reactive airway disease or asthma, TB for tuberculosis, and COPD for chronic obstructive pulmonary disease. So we've got the 4 different acronyms. So that's kind of fun, isn't it? You know, we can just like, you got to learn how to take care of your COPD, right? Anyway, so the other exemplars, TB is under infection, and then I think pneumonia is under infection also. And then here under our watch and learn videos, I wanted to see where they have the lung sounds too. So emphysema, we have different, have you watched these picmonics? I always think I could make up better ones because some of them are really silly. So do you go ahead and study these concepts and watch these different animations and things? So I have to get the sound on it, but anyway, we have those. And then when we go back and go under our textbook, so when we go under product view, or if we want to go under our chapters in our book, so in our medical terminology book, there's these different games that we can play. I think chapter 11 is oxygenation, right? The respiratory system. We can do this robo terms. It's kind of like hangman. Hemorrhage from the nose or nosebleed. Do you know what it is?
Epistaxis.
Yeah. Yay, right? So it gives you this positive reinforcement right away. Chronic dilation of the bronchus or bronchioles. Chronic dilation. Nope. Oh.
Bronchitis. No.
Chronic dilation. Bronchiectasis. Breathing difficulty that is relieved by assuming an upright position. You guys know this now, right?
Hypopnea?
Yeah. I guess I need an H in there, don't I? Okay, so practice with these, okay? These are a lot of fun and you'll learn a lot. I know, because you don't have enough to do, right? So in your downtime, do the games for the medical terminology. I know in one of these sections they're going to have our breath sounds and our lung sounds. So that's my medical terminology. And then you all have practice with medications, right? So you can always go back to your hanky med math. That's VSIMS. Okay, so I got to go back to product view here. So our med-surg book. So you have heart and breath sounds. And here's where you can have your normal breath sounds. Crackles. With a wheeze, right? You hear the crackles first and then the wheezing. So all these abnormal heart sound or lung sounds, these are called adventitious sounds is how we would term that. It's kind of a high-pitched expiratory wheeze. Okay, so you can play with those. I'm going to show you where all the good toys are in here. We have more picmonics for different respiratory things in here. Okay, so you got to go down to the chapter. Tuberculosis assessment is a picmonic. That's a good one. In lab yet, have they gone over the different O2 delivery methods in lab? Did you look at those last semester? The nasal cannula? What can you tell me about using a nasal cannula? How much oxygen can you give in a nasal cannula?
Up to 6 liters.
Yep. And when you're giving it, what are some considerations with using the nasal cannula?
Are they moving air through their nose?
Right? Is their nose patent? Very good. Yep. Making sure that you're putting the cannula in the right way so that it's not facing forward, so it's not going to be occluded by the tissue inside the nose, right? You want it to go with the curve of the nares. You never don't ever cut the prongs, okay? Some people think that that's more comfortable for the patient, but you're not accurately measuring the amount of oxygen that they're required that you're delivering if you're cutting the prongs. Oxygen can be drying, right? When somebody's on oxygen, it can be very drying to their upper respiratory tract, and that can make their secretions thicker, and it can also dry the nares and cause bleeding, right? And so what do we do to prevent the upper airway from getting dry with oxygen?
Humidified oxygen.
Yep, put a water bottle on it, right? Hook that up to your flow meter. Make sure that you're reading the flow meter with the silver ball right in the center of the line. So you're looking at it eye level, making sure you're accurately recording your patient's oxygen requirement, right? So, and with the flow meter, we can only do liters, right? We can do milliliters. We have low flow meters for the little infants and stuff, but you can only do liters of oxygen. So if the doctor orders a percentage of oxygen, what kind of delivery device are we using then?
Venturi.
Yep, the Venturi mask. Very good. So you got the mask on your patient. You've got the little dial flow below that you can regulate the percentage. Yep. So if you need, like, let's say you need a patient, you have a patient that needs like 60% or 70% oxygen. What kind of mask would you use for that? For that patient? What do you think? What gives you the highest percentage?
Non-rebreather.
Non-rebreather mask. Yep, very good. Yep. And you want to make sure you have enough oxygen flow to keep that bag partially inflated, right? So they're not completely deflating the bag and breathing their own CO2 back. You want to keep a good flow of oxygen so that they're getting that high percent. Very good. Okay, and then in our fundamentals book also, let's see, I'm gonna go back to product view. Okay, so next week we're going to go through the 4 exemplars: chronic obstructive pulmonary disease, COPD, reactive airway disease, or RAD, tuberculosis, or TB, and pneumonia, or our PNA, right? So we've got our 4 different acronyms for our 4 different exemplars. And then you're going to have team assignments where you're going to be doing a case study and a plan of care for your assigned exemplar. So I'll get you in your teams so that you can work on that. The following week when you come back, we'll be doing a quick presentation of those care plans. And I'll be giving you instructions next week on that. The following week, so week 5, we're going to have a quiz on oxygenation as a concept. And I'll be introducing acid base and looking at how to interpret blood gases. And then week 6, which that's taking us into October 13th, is going to be exam 2 on oxygenation, ventilation, and gas exchange, and those 4 exemplars. Okay, so just so that's chunked in your mind, here we are finishing week 3 today, and that's what we're doing week 4, and 5 is a quiz, and 6 is our next test. Okay? So do your reading assignments. I've assigned prep views in here. They're not graded and they're not a ticket in, but they're assigned just like your reading, okay? So do your reading, do your prep views. I've assigned them, I think, at a level 6. I think I did this. I either did a 4 or I think I did a 4 because I noticed that not many of you did it last time, so I kind of backed off a little bit because I want you doing them. So don't get discouraged. Do as much as you can. The more you do, the better. These interactive tutorials are really helpful. This one's on fluid and electrolytes. That's not what I want. So this concept in action animation. This one on gas exchange shows how
carbon dioxide is carried in the blood mainly as bicarbonate. How is it finally released as a gas on reaching the alveoli? It is done through bringing hydrogen and bicarbonate ions back together as carbonic acid, and then reversing the formation of carbonic acid, which yields carbon dioxide and water. These reactions occur in the red cell, helped by the enzyme carbonic anhydrase and also by the oxygenation of hemoglobin. The carbon dioxide so formed now enters the plasma and is able to diffuse out into the alveoli. All cells need oxygen. It is the essential fuel which is necessary to enable cells to stay alive and to carry out their various activities. Bringing oxygen to the cells requires the uptake of oxygen from the air in the lungs, its transportation in the blood, and its delivery to cells all over the body. The first step is the taking up of oxygen by blood flowing through fine capillaries in the walls of the lungs' air sacs, or alveoli. The oxygen molecules change from their state as a gas freely circulating in the air, dissolving into a solution in the plasma within the capillaries of the alveoli. Once in the solution of the blood, 98% of this dissolved oxygen is taken up by passing red cells, leaving just 2% remaining in the physical solution unattached. Red cells are particularly well suited to transporting oxygen because they contain a special oxygen-binding protein known as hemoglobin. Each molecule of hemoglobin itself contains 4 molecules of heme, an iron-containing pigment, which binds oxygen loosely and reversibly. Hemoglobin that is fully saturated with oxygen is bright red and is called oxyhemoglobin. On the other hand, hemoglobin that is not saturated with oxygen is purplish blue in color and is called deoxyhemoglobin. It is heme which makes it possible for the red cells to pick up oxygen dissolved in the blood, transport it combined with hemoglobin, and release it back into the blood as oxygen in solution, ready for delivery to the various cells of the body. Hemoglobin gives up its oxygen as red cells travel through capillaries in tissues where there is a low content or partial pressure of oxygen. The partial pressure of oxygen represents the level of dissolved oxygen in plasma. As oxygen is released and again is carried in solution, the partial pressure of oxygen in the capillaries becomes greater than the partial pressure of oxygen in the surrounding tissues. This causes oxygen to move out of the capillaries into the tissues and to finally reach the cells. This graph, the oxygen dissociation curve of hemoglobin, shows why hemoglobin is particularly suited to its role in transporting oxygen. The oxygen dissociation curve demonstrates the relationship between the oxygen carried in combination with hemoglobin, the O2 saturation, and the partial pressure of oxygen in the arterial blood. The sharp upstroke and the flat plateau illustrate how oxygen is released to the tissues over a wide range of conditions. Its shape means that although the partial pressure of oxygen in the blood returning from the lungs and being pumped out by the arteries may be reduced to only 50% of the normal value, say due to lung disease or high altitude, hemoglobin will still be 85% saturated with oxygen.
Okay. So you have these resources. There's more videos down here, but you can watch those on your own, and I'll post the link for the other video that was in our PowerPoint. The last thing I want to share here too, I'll stop sharing this, but there's more resources in here, okay? There's more case studies and things that you can get more in depth to help your understanding. And also, when you get your exemplar next week, look at these resources for, for COPD, for asthma, and for tuberculosis and pneumonia. Okay, as you're building out your team case studies, don't make it up. Use your resources and cite your resources. Okay, but like I said, I'll be giving you more detail into that assignment next week. So let me stop sharing this, and then I want to just share this other PowerPoint that shows kind of the, I guess I need to share again. Share screen, PowerPoint. Okay. Because I kind of skipped over just this, structure of the respiratory system. So kind of just getting familiar with the upper and lower airway. We covered this, the purpose of the respiratory system in terms of gas exchange. So don't forget that the respiratory system starts at the nose. You got your sinuses, your nasal passage, your pharynx. You talked about, things you need to consider with the nasal cannula, that they have patent nares and that they breathe through their nose. You got somebody who's a mouth breather, they're not going to do well with a nasal cannula. The pharynx, the tonsils, the adenoids, the larynx, the epiglottis and the glottis, the vocal cords and the cartilage. When you're intubating somebody, you're putting, a speculum and a blade in, and you're looking for these structures to know that you're going to go then into the trachea and that you're not going accidentally. You don't want to intubate the esophagus, you know, you don't want to ventilate the stomach, you want to ventilate the lungs, right? So these are key structures in identifying the upper respiratory tract. So, you know, and looking at what that looks like as a side view, and how then, you know, that the epiglottis is so important. You know, back in the day, I think sometimes as nurses, we think that we're not making these great, you know, this great progress in how, you know, medicine, we're not having these breakthroughs. But when I first started as a nurse, we didn't have that Hib vaccine, that Haemophilus influenza vaccine. And children would come in and they'd have stridor, and we wouldn't know if it was croup, which is less deadly, or if it was epiglottitis. Because if they have Haemophilus influenza that infected that epiglottis, and that epiglottis swelled, it would close off their airway like that. And even getting them to surgery and emergency tracheostomy was the only thing that would like save their life. So, you know, now that we have the Hib vaccine, we don't see cases of epiglottitis anymore. Okay, true or false? Purpose of the cilia is to move the mucus back to the larynx. What do you think? I'm trying to, Victoria, is it Victoria or oh, Ms. Almeida?
Oh, Vivian.
Vivian, I don't know why I had a mental block. Sorry about that. Vivian, yes.
That's true.
True. Yes. Remember the little fine hairs, right? Clear out that mucus. Here's the cross-section of the nasal cavity. So looking at those structures, the hard palate and soft palate and sinuses, you know, so palpating, you know, I talked about palpating the chest too, but also your book shows, you know, palpating the sinuses for tenderness and sinus infection. 2 lungs, right? 5 lobes. Left, we have the upper and lower. Right, we have upper, middle, and lower. There's pleura, there's the mediastinum, and then the bronchi and the bronchioles as we're going out and down, and then ending in those alveoli sacs where gas exchange takes place. Okay, and this shows you very nicely this picture. You know, when we look at that chest x-ray, we want to make sure that that diaphragm is intact and that those lungs are completely expanded in that diaphragm, that muscle. So the alveoli is where gas exchange takes place. Surfactant is a substance that it's a lipoprotein that the body produces to keep the alveoli from collapsing. It helps keep the alveoli open and lubricated so that they're easier to expand. Premature little babies don't have surfactant, and that can lead to bronchopulmonary dysplasia. So a lot of times newborn, if they're premature, they can gavage and give surfactant. So this is, you know, a picture of what the lobes look like, the different lobes of the lungs, the branches of the bronchus, and then the ending in the littler bronchioles. And then just explaining perfusion and how that diffuses out. And I think that video did a nice job of explaining how we have pressure in our lungs and how, you know, like with pulmonary hypertension and stuff, how increased pressures, how changes in pressures in our environment, like if you're up in higher altitudes and things, how that changes, how then, you know, oxygen is diffused and transported. So, and then the importance of then also excreting carbon dioxide. I like to call it carbon diacid. So I remember that carbon dioxide is the acid in the body that needs to be excreted by the lungs. Okay, so respiration is that process of gas exchange. Ventilation is that process of breathing. Okay, just if you ever wondered what's the difference in those two terms, just keep it simple, right? I think of ventilating the patient, giving them breaths, right? And then I think of that respiration is like the plant giving me oxygen, and then I respire, right? And I give the plant the carbon dioxide it needs. So I have this symbiotic relationship with all of nature around me, right? So respiration, expiration and inspiration in the respiratory cycle. Gas exchange, so this middle part is the alveoli sac, right? And then you see the bottom part is that venous and arterial system kind of coming along. So this is kind of our picture. And don't ask me why it's called VQ, right? But the ventilation on pressure is called VQ mismatch. And we'll talk more about that, okay? I'll show you a video. The link, the video is on this whole VQ mismatch. So if you don't have enough ventilation, then you have a ventilatory mismatch. If you don't have enough perfusion, then you have the Q mismatch or the circulatory mismatch, okay? And I'm kind of out of time, so I'm gonna end it here, review the PowerPoints, do your reading. When you look at your chapters, make yourself an outline, take notes as you read along, so that then when you get your study guide later, you can go back to your notes and you'll have part of that work already done. Do your prep use, refer to your resources, and I'll see you back here next week. Okay? Questions for me? I'll be doing the exam analysis and getting out grades as soon as possible. Thank you for your attention. I know it's hard on an exam day to change focus and move on, but I feel like you guys were all taking it all in, right? You're excited to be getting into the nursing stuff, right? This is what it's all about. This is the fun stuff. Okay, and there is going to be a ticket in. It's a crossword. Just kind of a fun to get familiar with the terms, okay? Don't sweat it too much, it's not graded, but I'll have that all set up. The crossword is posted in the week 3 folder, and I'll have a place for you to submit that coming up shortly. And I'll send you out a reminder before the next class. As you go, oh, wait a minute, never mind. I was gonna send you a reminder making sure you checked your attendance, but I checked it and everybody did it. Good job, class. You all did your attendance, thank you. Okay? Have a wonderful evening. I'm going to hang if anybody has any questions. I'll be posting the lecture too, okay? A link to the YouTube.
So Ms. Erickson, really quick, I just want to make sure I got everything. So the prep use, the reading, the ticket in.
Yep,
and
that's it.
That's it for this week. And then our quiz is on week 5.
So
and then
next
our
week,
exam week 6.
week 4, you're going to have a team assignment. Week 5, you'll have a quiz. Week 6 will be the exam.
Okay, got it.
So you know what's coming. Remember to refer to your quick view outline under the course syllabus tab, okay? If you haven't printed that out, go ahead and print it out, and then you'll have it to refer to the readings. All the assigned readings and everything are in there.
Yes.
And it is also posted on the folder when we first go to sign in for the week, it's on the folder too.
I like to double check because sometimes it changes, so.
True.
Okay.
Sometimes I'm a little inconsistent. I don't, you try to have everything exactly the same wherever you put it, but the more places you put it, the more your chances for being inconsistent. That's why we tell you not to dual chart in different places, right?
Right.
Send the chart one place.
Definitely.
Right.
Thank
Try
you.
not to duplicate. Otherwise you can run into errors.
Yeah. Okay, thanks.
Okay. Yes.
Mine questions at school related, but I wanted to see if you knew my mom from working at TMC, because she was a newer nurse back like early 90s. But her last name at the time would have been Klein or Seed, or Kim Klein or Kim Seed.
Kim Klein. Boy, that sounds really familiar, really familiar. And I knew Klein sounded familiar anyway. What area did she work?
I think she was I'm not entirely sure because she was just coming out of like nursing school, I think, during that time period, but she ended up being in float pool mostly.
Yeah, I can't really place her, to be honest, but boy, the name's familiar.
That's totally fine. I asked her too. She's like, I need to see her face before I know.
Right?
I said, okay, I'll work on that.
TMC was such a big place, I did all my time in peds, so other than if I floated to Mom Baby or something like but boy, that name is really familiar, Kim Klein.
No worries. I appreciate it. Have a great day.
Thank you. How's it going, Shelby? And I got your email. I'm going to just get with Jen. I'm going to get with Ms. Morelli about a time, okay?
Okay, I had another question, but I just wanted to talk to you privately. I don't know if anyone
Vivian,
else
did you
needs
want to
or
talk to me
not, but-
privately too, or are you okay?
Yeah, I just have a quick question.
Yeah.
It's about the crossword puzzle because I think number 4 and number 10 are reversed.
Okay.
So
I don't remember it being a problem from my key. I'll check it, okay? I'll check it and I'll email you 4 and 10. I'll check on that.
4 and 10. I think so. I don't know. That's just wanted to check. But yeah, that was it.
Yeah, there's one that you don't put a space in and, or something like that. You just write it all out. That's a little bit confusing, but.
This one's just the definitions because number 4 says exchange of oxygen and carbon dioxide in the alveoli. So that's respiration, right?
Right. Yeah.
But the word that fits there is actually
Ventilation.
ventilation.
Right. Yeah,
Okay.
You're right. I think they got transposed. Yep,
Okay.
I remember that now. Thank you.
Then I'll just leave them as is. I just wanted to make sure.
Okay. Yeah.
Thank you.
Thank you. Okay. The other one's me too, Shelby. So I just had 2 computers.
No, you're fine. So yeah, the one thing I wanted to bring up was the email about the open lab for me to come in and do that skill that I'm going to be missing because I'm going out of town that weekend.
Yeah, and that's on October 6th.
It will be, the open lab is I think on October 7th.
Okay.
It'll be a Wednesday.
Yep.
I would be coming in before I do my actual lab date for that day in the afternoon. I'm like the very last lab day or lab time for our group. And so I'm in there at 3 to 5. And so anytime before that, I can come in. I just don't know how long of a time we need to complete the checkoff.
Yeah,
so
I don't know either because it's for nursing 111. So that's why I want to talk to Ms. Morelli and see what she thinks, because I don't want you to be rushed either.
Yeah.
Yeah, but is it like an oral med skill or what? Because she said she was going to have like the medication administration record and that whole thing.
Yeah.
So,
I think it's an oral med. It's oral med with the MAR and the three checks and then the 3 or the 6 rights or whatever I think is what it was.
So just kind of loosely, it sounds, so if you have your sim at 3, right? At 3?
No, I have I have 126 lab at 3. We don't have sim that day.
Okay, good. I'm sorry, I'm getting it confused. Okay, you guys do you have sim tomorrow?
We do have sim tomorrow, yeah, but we don't have sim every Wednesday.
Right,
it's only
right.
We only have 3 sims a week.
Right. I taught 126 lab. Usually I've either taught this is the first time that I've taught the class and not taught the lab with it. But I wanted to teach both classes just because I've been teaching them, you know. It's just funny that we have 2nd, 3rd. So yeah, so I thought this would work out well. We'll see how it works. But yeah, so how are you guys doing? Get ready for sim tomorrow for your first sim.
I'm a nervous wreck, but you know, we'll see how it goes.
That's why I wanted to just review the oxygen modalities a little bit.
Yeah.
But it is funny because like in the past, I've always organized it so you didn't have a test and a sim in the same week. But I think because of class being on Tuesday and it being week 3 and then lab being week 4,
yeah,
you know, without having the same instructor to look at it more closely, you know.
Yeah, it's fine. I mean, and we have 2 exams on Friday, so it's like
so it's week from hell.
Yeah, I mean, we've had it last semester. I think we had 4 exams in 1 week, so it was a great fun that week. But I mean, it's hard when it's a week starts on a Wednesday and ends on a Tuesday. So it's like
I still haven't figured that one out, I'll tell you.
Yeah. And that's the other thing I wanted to bring up to you right now. I'm actually going to be driving back on that Tuesday that we have our exam 2 from Texas.
Okay.
So I'm hoping not to be in the car on Tuesday for our class.
Right.
But I'm not sure if that's going to be, I don't know honestly what time we're going to be making it back because like I said, we're driving back.
What is it? Why are you going to,
I'm going to Texas, one, just to be able to visit family, but Mimi and my mom are driving back to Tucson and they want to do like a little road trip. So I'm driving back with them to help them do like the driving part.
Gotcha. Yeah, unfortunately for that reason, you know, if you do miss the exam, it would be the 10% deduction.
Yeah. So I didn't know if there was a way to do it early or anything like that, because I know in the past some people have. Okay.
I can ask about it, but not for that circumstance. It's for like a one time, you know, like if it was a funeral, you know, a military thing, something that is you know, you can't get out of.
Yeah.
So for other stuff like that, we don't.
Okay. Yeah, when I looked at the calendar, I didn't see that there was an exam that week. So I like just misplaced my weeks, I guess.
Right. I mean, you know, fortunately with us being online, if you were someplace, you know, all you need is that, you know, place that you're got internet and you could do it. But
yeah, well, I'll bring it up to my my family and let them know that we need to be back in time for me to take that exam. So
yeah. Okay. Thank you. I know, yeah, at least we got time to plan, right?
Yeah.
Yeah. Okay. And so just loosely, I think it sounds like 2 o'clock on October 7th would work, right? So we have plenty of time before you start lab at 3.
Okay.
Okay.
That sounds
So
great.
I'll just see if Ms. Morelli thinks that sounds fine, and we'll finalize that. Yeah.
Okay. Yeah, because we have a lab for her on Friday. I don't know what we're doing on Friday with her, but I know we have a lab with her on Friday, so I'm wondering how long like that will last. I think her time slots are like an hour long anyway, so I think it should be an hour should be fine.
Right. Yep. Okay.
Okay.
Thanks for letting me know. Okay.
All right.
Yep. We'll work it out, right? Take care, Shelby.
Bye.
Bye.